then now we're at the anterior lung with the patient supine. Does anyone see impaired lung sliding, or do they think there's good lung sliding? Good lung sliding, okay. So my argument in this kid is that we're dealing with hypovolemic shock. The only thing that we found in going through all those chest, cardiac, lung views was a collapsed IVC. So maybe they've been a little bit more vomiting than you thought, or sicker for longer. They could still be septic, but the collapsed IVC kind of pushes me in the hypovolemic direction. Uh-oh, here comes the exact same kid with the exact same vitals, the exact same appearance. I hear pericardial effusion. I like it. And what view are we using to capture that? A subxiphoid, yeah. So what's the thing, the moment that you say pericardial effusion, what's the next question I want you to answer? Yes, yeah. And then how would you look for tamponade? What side of the heart, right or left? Right. Okay. So as it plays through, I know that this is a young kid, it's a fast sweep, the heart doesn't sit still for you long. Do you have any concerns about possible tamponade? Tell me where.
Where?
Yeah, so the free wall of the RV looks like it might be inverting a little bit. And then if you watch the free wall of the RA, you'll see for an instant more of a sense of inversion. And that's where you can put a M mode spike over and get a nice tracing and really tease that out. But one of the things to keep in mind, this is a large pericardial effusion, right? And those are the ones that often avoid tamponade, or they develop tamponade later in their process because the pericardium needs time to stretch. So we're used to looking at images that have pathology and saying, whoa, there's more pathology, I'm worried this kid is more sick. But I'm more worried about tamponade in a small pericardial effusion than I am in a large one. A large one's actually kind of reassuring. Because if you have rapidly accumulating blood in your pericardial space, it's going to cause tamponade pretty quickly. So you'll have that, 1 centimeter, 1.5 centimeter fluid rim, and your patient will be shocked and dying. So there's these things that we teach a lot about in point-of-care ultrasound, and you don't encounter them that often, but you kind of develop a body of knowledge that's around the things you can find in point-of-care ultrasound. So, that point about a smaller pericardial effusion being more worrisome is one. What's the first treatment you call for when you think you have tamponade? So pericardiocentesis is what everyone says, right? Our definitive management, right? So to support that preload, I need a stat bolus and a cardiology consult and a pericardiocentesis kit would be my call out. And you'll probably have the bolus running faster than you can find the pericardiocentesis kit or get your cardiologist to the room. So, another argument I'll make in this slide is that sometimes I will always be preaching, do your full, cardiac views and lung views and do all of it. But if this is like the first thing you find, I also want you to act on this and then come back to doing other scanning later. Sorry, Hazel, I interrupted you. Oh. Okay, so then that's an example where POCUS gets you to a diagnosis of obstructive shock much quicker. And these are two kids that can present looking exactly the same, right? With this picture, I didn't include these slides, but what would you think that the IVC would look like? plethoric. Yeah. So you got a big pressurized bag around the heart that impedes filling. That's the pathophysiology of tamponade, so that IVC should be big and plump.
So was that a tamponade?
Yeah, it was a pericardial effusion. That specific patient ended up being one with an autoimmune hepatitis. And this was just their first presentation with all kinds of weird stuff out of whack everywhere. And it was a case of the like sonographic tamponade kind of preceding clinical. So they didn't go for like a rush stat drain. They went for one like 6 hours later after making sure they got like bolus, they got the theater ready, a little bit more of a controlled process than like a crash pericardial centesis in the ED.
If I'm not convinced, I want to put my emerald. I can't put it in the center, right? I can't put it like so I can see like that.
You can put it in any view where you think you're intersecting the wall in the way that you want. So sometimes it's a matter of trying to move your hand around in either a subxiphoid or a parasternal view to intersect that wall. There are machines that have the ability to do something called anatomic M mode. So when we do M mode, the spike always originates from the face of the probe. But some of the machines let you do like a bunch of computer processing, and you can put an M mode spike laterally across the screen or horizontally across the screen. And then just to say,
like in your practice, let's say,
I just use myself. I use the visual, like I'm seeing inversion of one of these walls, and I know that when cardiology comes, they're going to do some M mode stuff. They're going to do some valve flow velocities that further back up like how bad the tamponade is. But I'm the screener, and I just call after that point. And then because we're talking about obstructive shock from pericardial effusion, we should just talk a bit about what it looks like in other views. So here's a pericardial effusion in a parasternal long. And how do I know that it's pericardial and not pleural? Yeah, everyone's saying because it tries to wedge itself in front of the aorta rather than heading behind it. Here's our thoracic descending aorta, and here's the point of the pericardial effusion trying to sneak in front. And we said we would expect a plethoric IVC, and there's an example of what one looks like. And we would not expect there necessarily to be a pleural effusion. So here's our left upper quadrant view with no pleural effusion. And we would expect good lung sliding. So then, we've done our first view that tells us, oh crap, we've got a problem we need to act on now. And then we still want to make sure that everything else fits with the picture. So that's the obstructive picture where everything else is basically normal except for a plethoric IVC.